So move to second case from Colin.
Hello, hi, I'm Huda from Chess Hospital Kulim. I'm presenting about this patient, Cik Asma. She's a 69 years old Malay lady with DM, hypertension and CKD stage 3. She was actually had one of initial admission in July 2025 for CAP. At that time, we had difficulty weaning off oxygen, so she proceeded with CTPA, which showed subsegmental PE branch at right middle lobe pulmonary artery. So she completed actually 6 months of DOAC and it was already stopped. Social history, she's a retired school teacher, school clerk, with no history of PTB or PTB contact. She had no exposure to dust or birds. She complained of post-discharge, she complained of exertional dyspnea since discharge with no other failure symptoms and also denied any CTD symptoms. SpO2 on room air was around 87 to 90%. No clubbing lungs. There's a cross cracks bilaterally, lower zone bilateral lower zone more than upper or mid zone. So on the CTPA done in July, there's a small non-occlusive PE subsegmental branch, and also noted there's a diffuse fibrotic interstitial lung disease. So spirometry actually was done. FEV1 was low. FEV1 over FVC only was 72%, but FVC was very low only 43% predicted. So echo was done with normal EF and PASP actually normal. It's at 12.8 only. That was correction. 12.8 not raised. ANA was negative. 6-minute walking test, she was only able to complete about 2 minutes walking, about 60 meters only before SOB. The SpO2 actually dropped from 92 to 84%. TB workup was negative. The reason for discussion was to look at the CT pattern and management. She had another admission for exacerbation end of May, but was able to discharge without oxygen.
All right, this is Gloria here. Thank you for the history. So I'll be presenting on the scans, 2 scans of this patient, Chair Asthma. So I have 2 scans here. One is in July 2025, which is on my right, and then it's a CTPA, as well as the other one is in May this year on my right side. So I shall begin with the first scan, which is done in last year. This is a CTPA. So as I scroll down, you can actually see it's actually very busy scan. Ground glass opacities with a lot of lines, reticulation or interlobular septal thickening. It's actually show a bit of crazy paving appearance in the central and also peripheral region. But if you can bear with me, there's actually areas we can see there is air trapping. There is areas of ground glass and there is areas of normal lung, but this is accentuated by the presence of contrast. But otherwise, it shows such other 3 density sign. So there is also bronchiectasis. We can see in the bilateral lungs. Okay, sorry. So as we scroll down, we see almost diffusely in the bilateral lung. So here is more areas of air trapping. Okay. So moving on to the mediastinal window, there is a PE in the subsegmental branch of the right middle lobe. I can see the segmental artery that has PE. But otherwise, actually, I'm not too sure about the value, but from here, we do see that the pulmonary trunk is a bit dilated. Yeah, so we probably would suggest to work up on pulmonary hypertension. Otherwise, there is a bit of reflux into the IVC, contrast into the IVC. Probably would suggest that could be features of pulmonary hypertension. Okay, so from this scan, with the three density pattern sign as well as the hard signs of fibrosis, we think that this is a fibrotic HP. Right. So moving on, if we see for the next scan in 1 year's time, you can see there is a lot of breathing artifacts, but you can still see the more areas of air trapping here. You can see it's more than compared to last year, as well as there's a lot of mosaic attenuation. And then you can see actually there is increase of areas of involvement compared to last year. And probably that in the same time, there's a lot of ground glass opacity going on. Maybe it's because of ongoing infection as well as exacerbation. Okay. From here, we do see also there is enlarged lymph nodes. The largest one is actually station 6 here. Yeah, actually a lot of enlarged lymph nodes. So with this, I want to conclude that this is a fibrotic HP pattern, worsening in fibrosis as well as with possible ongoing infection or exacerbation. Any questions?
No, Gloria, thank you. Huda, right?
Yes.
Yeah, so patient, you need to get a further history to look for allergen, any mold or any bird at home. Then you need to elective admission, give material prep because looks like HP acceleration. So we give material prep. I mean, you do workup, CRP, everything negative. So give material prep for 3 days, and then after that we start prednisolone and MMA.
Okay, boss.
The important is the allergen lah. Need to identify the allergen. So need to removal of allergen is most important lah.
Okay. Noted, boss.
Okay. So we move to second case from cooling.
Okay, good afternoon, doctors. My name is Arun from Hospital Kulim. I'm here to discuss one of our patients, Madam Komala, 62-year-old retired chocolate factory worker, now a housewife, non-smoker with no known allergies before. Pre-morbidly, she has hypertension, subclinical hyperthyroidism, and history of COVID-19 Cat2A infection in 2020. She was presented to us to our chest clinic with a complaint of chronic cough, exertional dyspnea with MMRC of 1 to 2. Otherwise, no hemoptysis and no loss of weight or loss of appetite, no nitrites or no PTB contact either. There is no chemical or bird exposure prior to this, and there's no CTD symptoms in form of joint pain or joint swelling. Clinically, there was no finger clubbing. There's no cervical lymphadenopathy. SpO2 was about 96 under room air. Lungs were actually clear. Severe tourism pneumoma, no palpable mass per abdomen, and there was no pedal edema. Sputum AFB was TB workout done in KK. Initial AFB ×1 ×2, no AFB seen, and sputum MTB CNS also no MTB detected. 6 minutes walking test still pending. CTD workout in form of rheumatoid factor was negative. C3, C4 was normal as well. Lungs parametry done in an early form of early appointment showed FEV1 of 58% predicted with 1.06%. Sorry, doctor, we cannot hear, doctor.
Okay, sorry, I forgot to unmute. Okay, sorry, let me start again. So basically there is reticulation and also traction bronchiectasis in the bilateral lung fields. You can actually see in the periphery as well as the peribronchial vascular region. So we can see more of a traction bronchiectasis as we scroll down to the lung bases. But otherwise, if you see the soft tissue window, there's nothing, not much of findings that is significant. There is no pericardial effusion, no pleural effusion. There is no enlarged lymph nodes as well. Pulmonary trunk is not dilated. So in this study, this one I will give as a fibrotic OP pattern. Yeah. Any questions?
Fibrotic OP. So the myostatic panel is done.
No, doctor, mycetic panel not done yet.
Okay, so Gloria, so you thinking the fibrotic OP more to CTD associated, is it?
It could be, yeah. But then again, it's anterior upper lobe sign, but otherwise, yeah, can be CTD related.
Okay, thank you, Gloria. So Aaron, send for the myostatic panel, see whether patient can afford to send for myostatic panel. So for now, we start prednisolone 30 mg OD and MMF. Then update me once the myostatic panel is available.
Sure, doctor. Thank you so much.
Okay,
Thanks, Subra.
thank you. Hey, Sumitra. Okay, we go to the Cebu cases.
Hi, I'm Ing here from Cebu Hospital. This is the first case from Cebu. I here Mr. Billy, 42 years old gentleman. He's an ex-welder from Cebu, hypertension and some pre-diabetes. She was actually referred to our clinics after initial admission in hospital Kulim. So he's an ex-smoker and vapor, 10 years, stopped 3 months ago, ex-alcoholic. He was working as a welder in Johor, but now he's unemployed. There's no obvious significant family history. There's some avian exposure like birds and chickens at the longhouse, but there's no other significant aerosol. So in April 26, she was admitted to Kulim for pneumonia. However, all the cultures and TB workup was negative. So during the first review in Kulim, after the discharge, there's persistent bilateral consolidation on the chest X-ray. Then there was proceeded with CT thorax. And the CT thorax was reported with cardiomegaly, pulmonary hypertension, and SP with OP pattern. So when she first come to our clinic, we explore the history. The patient actually has been having chronic cough even before the admission to Kulim for around 4 to 5 months. MMRC was 2 with occasional PND and on and off lower limb swelling. So he also, when we review in the clinic that time, she is already euvolemic, no clubbing, no CTD signs, no myopathy, no edema. There's some bilateral fine crepitations over the lower zone. So during that amount of time, echo was not done and it was ordered later on in the clinics and it came back actually the LVVF only 10% with a calculated MPAP of 29.3, subject of pulmonary hypertension. So the autoimmune workup was sent because of the CTE findings, and it was came back negative, and DSDNA was negative. The only thing positive was CN1A2 positive, which is actually inclusion body myositis associated. We have consulted rheumatology side and neurology side. Actually, there's no clinical signs. So other than that, there's a PCNA borderline positive also. CKRF was all negative. So we have consulted cardiologists also, and cardiologist, she was planned for this cardio right heart catheterization and COROS in the 30th of July, which is still pending. So for our current, we are also planning to repeat the HRCT later as there is a diagnosis of heart failure. But when we review in the clinics, actually clinically, he's no longer hypervolemic. So we would like to discuss on the CT scan findings and also the further management for this gentleman. Thank you.
Thank you for the history. I'll share my screen first. So scrolling, this patient has only one CT, which was a contrasted study, recon into lung window. This was a CTPA. So from this study, there's diffuse bronchocentric ground glass densities and also consolidations at bilateral lung fields. There's presence of some atoll sign, reverse halo sign, as well as perilobular densities. which is more pronounced on the bilateral lower lobes. Bilateral lower lobes. As we go down, the perilobular densities are more apparent, and there's also bilateral ground glass densities. There's presence of fluid within the right oblique fissure as well. Other than that, like, we can also, as we see within the ground glass densities, there are multiple ground glass nodules scattered in predominantly at bilateral upper lobes as well. Okay. There's no pleural effusion. Okay. As for the soft tissue window, which was called CTPA, so we can see there's no multiple enlarged lymph nodes, mediastinal lymph nodes at 4R, 4L, multiple at station 6 as well, 10R. The pulmonary trunk is borderline dilated, measuring up to 3 cm. Up to 3 cm. And there's pericardial effusion. There's no right heart string signs where there's no bowing of the interventricular septum, and there's no reflux of contrast within the IVC as well. Upper abdominal organs are mostly clear. So these CT features are suggestive of organizing pneumonia pattern. Any questions?
So can be the organized pneumonia like a post APO, like reabsorption edema, resolving edema?
Yeah, possible is because of recurrent pulmonary edema, and they can cause chronic because of causing the AOP pattern. But there's no at this point there's no significant interlobular septal thickening to suggest any active edema, just that other residual fluid within the fissure.
Okay. Yeah, I noted there's no reticulation, there's no traction disease. So I thought it's more to like a resorption edema, means resolving the edema.
But there's presence of the perilobular densities and also the atoll signs of
Okay.
OP pattern.
That's possible due to previous previous infection or previous fluid overload.
Can you give
Hi, Subra. I think it's we think of infection dulu lah, rather than pulmonary edema. Maybe infection caused this first.
So another CT scan repeated in 3 to 4 months should be can get a clear picture, right?
Yes, perhaps. But at this point, memang there's no signs of fibrosis lah, but there's a lot of stickiness. Those OP, very typical features of OP lah. Even the atosai pun ada. Kan nampak everything is very sticky.
Yeah. So possible previous infection is most likely.
Betul.
Okay.
Betul.
Okay, thank you, Dr. Irene. Thank you, Dr. Emra. So so we repeat another CT scan in a 3 months time HRCT, then we see how's the progression.
Thank you.
Okay, second case from Cebu.
So proceed to the next case. This is Madam Ling Guo Sing. So she's 74 years old lady, diabetes, dyslipidemia, hypertension. So she was just presented to us first in last year, December, and mainly admitted for infective symptoms with cough and fever. So it was diagnosed with influenza B and completed treatments at that time. However, during the admissions, the chest X-ray noted there's a bilateral lower zone consolidative changes. We have proceeded with TB and workup. So TB GS was negative, but later on when we trace back, the TB cultures came out as NTM, only labeled as mycobacterium species, but no further elaborations. So echo, we also ruled out heart failures at the time as there's some pedal edema, but pro-BNP echo was grossly normal. There's no significant exposure noted from the history. Clinically, she has some mechanic hands with, however, there's no clubbing with some fine crepitation over the lower zone. Clinically, there's no evidence of myopathy and no scleroderma features. So we proceeded with autoimmune panels as this influenza pneumonia at the time doesn't explain the other findings clinically. So ANA came back positive, 23-1. Then DSA were negative. ENA panel only SCL70 came back positive. And also that time, because of the mechanic hand, we looked hard for myositis panel. The HMG came back is positive with some statin association previously and already withheld since then. However, the CK that time was normal. So when we see her back, we did repeat the HRCT in the April. There's still 3 density signs and also diffuse central lobular nodules with some residual consolidation. Decided to bronch to rule out any airway infection. Airway was normal, but the cultured straps viridans, and we have treated her with ES for 2 weeks. TB expert during the bowel was repeated, was no growth. As of today, the TB culture from the bowel is still so far no growth, no repeat growth of NTM also. So pulmonary function test, FE1 was 104%, FE-FVC ratio was normal, 6-minute walking day was 320 meter. Echo repeated is still, echo that time was normal. There's no steroid initiated so fast. So for now, our impression was ILD with favoring possible IP, and the myositis panel is slightly non-related. We also refer to rheumatology, and rheumatology also thinks it's unlikely myositis ILD. So we want to discuss about the diagnosis of HP versus CTD ILD, and we will actively trace the bowel TB-CNS, see any recurrence NTM infections, and also serial CTs to follow on the nodules on the X-rays, on the CT, sorry. Yeah, thank you.
I'll share my screen. So this patient has 2 CTs that was done in the interval of almost 6 months. First one in December last year, and the later one was in 4 months, was April this year. So the first CT was a CTPA reconstructed into HRCT. So scrolling from craniocaudally, we can see there's multiple bilateral diffuse bronchocentric ground glass densities predominant involving all lobes. And also consolidations spanning the right upper lobe. So some of these ground glass densities are associated with interlobular and intralobular septal thickening, giving rise to crazy paving patterns. As we scroll below, there's dense consolidation at the bronchocentric consolidation as well at the superior segment right lower lobe. There's also perilobular densities, which are seen at the bilateral lung bases. Other than that, as for the right upper lobe, multiple centrilobular nodules are scattered with some giving tree in bud patterns. Okay. Several lung nodules are also, solid lung nodules are also seen with central calcifications at the bilateral apices, likely in keeping with granulomas. Other than that, as we go to the soft tissue window, during the first soft tissue window in December, there are some sub-centimeter lymph nodes only at 4R. Pulmonary trunk is not dilated, and there's no pericardial effusions. The upper abdominal organs was clear at this time. So based on the first CT, we suggest these CT findings are of OP pattern, organizing pneumonia pattern with ongoing infection. So the follow-up CT, which was done in April this year, this was HRCT lung. So the previously seen the crazy paving pattern has mostly resolved in this study. However, there's still residual consolidation, persistent consolidation at superior segment of right lower lobe. And the perilobular densities are more pronounced in this study. At this time, there's a lot of centrilobular nodules in bilateral lung fields, scattered with train bud patterns. The earlier seen granulomas are quite stable in this study. Okay. Again, from this study, the plain CT study in the soft tissue window, we see only sub-centimeter lymph nodes, no pericardial effusion, there's no pleural effusion as well. Upper abdominal organs are just clear. So from the later on CT shows that still there's presence of organizing pneumonia pattern with resolving infection. Due to the presence of persistent consolidation at superior segment of right lower lobe, we would suggest for a CT reassessment.
Okay, thank you.
Any-
So, I mean, CT reassessment we can be done in so this CT is April. So, should we repeat done in 1 month or 2 months time?
Maybe around 3 months.
3 months. Okay, thank you. So, Shankar, you need to follow up with the BL MTB CNS. This one looks like more to NTM with superimposed pneumonia.
Okay.
And rather, there's no CTD features, so not for steroid or immunosuppressant. So the BL CNS this time is already treated, right?
Yeah, we treated the strep viridans
Okay,
for 2
maybe
weeks.
maybe you can repeat another sputum CNS and follow up with the BL MTB CNS
Sure.
and arrange for another CT scan 3 months from the last CT.
Okay, sure. Thanks.
Okay. Okay, third case
So-
from Cebu.
Yeah. So this is our last case from Cebu. Thank you. So my patient is Zaina binti Zatib, 65 years old lady with hypertension and hyperthyroidism. Actually, he was referred from a district hospital because of abnormal chest X-ray findings. History-wise, he has chronic cough and shortness of breath for past 1 year. For the past 3 months, the symptoms has been worsening, hence the visits to the district hospital. He was some loss of weight, loss of appetite. MMRC is bad 3 to 4 upon presentation. There was no prolonged fever, no CTD symptoms, and PDV workup extensively in the PK was negative. There's also no significant exposure identified. Clinically, patient is very cachectic, mildly tachypneic with only baseline SpO2 of 88% on room air. There is no clumping noted. Lungs is bilateral, lower zones fine crepitations. Clinically, no scleroderma features, no heart failure features, no myopathy. Autoimmune extensive panel came back negative, and CT thorax done earlier and it's suggest of UIP pattern. Lung function test-wise, patient is too fatigued to perform a spirometry and 6-minute walking test. Echo, however, already showed there's evidence of pulmonary hypertension. Our impression initially was looking at an advanced stage IPF, and we wanted to discuss the CT findings, and also likely this patient will need the antifibrotic of OFF during our follow-up. Thank you.
Okay, thank you for the history. So this patient had only one CT scan done. So this was a plain HRCT. So scrolling craniocaudally, there's reduced lung volume, there's diffuse ground glass densities and articulation, there's presence of exuberant honeycomb cyst with traction bronchiectasis. We can see presence of anterior upper lobe sign. And there's also as we go towards the bases, the motion is quite bad, but I think we can still appreciate the presence of a straight edge sign as well. Other than that, as at the bilateral apical region, this patient also has irregular triangular pleural thickening with subjacent traction, consolidation and traction bronchiectasis, which is better appreciated on coronal study around this region. All this triangular pleural thickening associated with presence of suprasternal notch and also platithorax in keeping with PPFE. Okay. Other than that, as we go to the soft tissue window, The pulmonary trunk is slightly dilated. This patient has multiple subcentimeter lymph nodes at 4R, 6, 10R, 7, and 11R. No pleural effusions. Upper abdominal organs are unremarkable. So from this, the CT features are suggestive of column 4 UIP pattern with PPFE and also PPFE. CTD ILD needs to be considered. Dilated as well as there's presence of dilated pulmonary trunk. Any questions?
But how about HP pattern? Because it's if a CTD rated is, I mean, HP easily can, I mean, be like a cyst like this. Yeah, just say advanced HP can be like this. I mean, with the UIP pattern with the cyst.
Possible of indeterminate HP pattern.
Patient, yeah, don't have any CTD features and CTD any negative. With the cyst, I mean, it's so advanced. I thought it's more to HP.
Boleh Subra. Can.
Okay.
Can. I mean, of course, first kita akan sell CTD dulu lah. But then there are few mixed features kan, like you said. Because even advanced fibrotic HP pun boleh jadi macam ni kan.
Yes.
So it's our differential juga.
Okay.
Alright.
Okay. Thank you, Dr. Yamuna.
Thank you.
So, Shankai, I need to explore any allergen, and we can start some low-dose steroid and MMF, and you can also find any option for antifibrotic. It looks a very advanced HP.
All right. Okay. Thank you
So,
very much.
do you have any option for antifibrotic?
As I remember from the district at first, there's some sponsorship in the family, but I will need to clarify again. Yeah, we will clarify
So
again.
for meanwhile, you can give plan to start the MMF and steroid first.
All right.
Then after 1 month, see how the symptoms. Then you can if you have option, you can after that initiate the antifibrotic.
Sure. Thanks a lot, everyone.
Okay. Okay, we move to next case from Sandakan.
Okay. I'm going to present Nurul Hafiza Liana from Sandakan. She's a 34 years old housewife, as non-smoker, and she's allergic to hydroxychloroquine, IM depot, MMF, and AZA, where she will develop rashes. Her issue under us is MCTD, predominant SLE with shrinking lung syndrome. Is diagnosed since 2018. She's on cyclosporine 150 OD and prednisolone 5 mg OD. Antibiotic-wise, ANA is 1 in 640 speckled, and dsDNA is 169 is positive and with low C3C4. ENA-wise, she's positive for RNP and was repeated again where anti-Smith and also RNP was positive. Clinically, she's MMRC1 with intermittent non-productive cough. Lung function test shows restrictive lung pattern, and we want to discuss the latest CT whether there is progression of the fibrotic NSIP.
Yeah, good afternoon, everyone. Dinesh here.
I think you have to allow us to share the screen.
Sandakan, radiologist for Sandakan, is it?
DK, sorry.
Oh, okay, hold on. Okay, done.
Okay, good afternoon again. I'm Dinesh here. I'll be presenting on the CT of this patient. Can everyone see the images?
Yes, can.
So the image above is the latest CT done in June of this year, and the CT below is the previous CT done in February of last year. So it's about 1 year and 3 months apart. So scrolling cranial to caudal, we go to the lower lobes. We can see there is some ground glass opacities at the peripheral regions of both lower lobes with areas of subpleural sparing. So you can see here, which I will show later on the coronal and sagittal view, which is more obvious. Again, we see the areas of subpleural sparing and bilateral lower lobes. And also at this region, also we see some ground glass opacities. And we also see minimal ground glass opacity at the anterior region of the right upper lobe. And when we look at the latest CT in this year, June of this year, we see that the ground glass opacities at the peripheral regions of both lower lobes appear more coarse. And also, there's subtle bronchiolectasis seen in the latest CT, which I will show on the coronal and sagittal views. So you can appreciate this is a dilated airway, keeping with bronchiolectasis. Sorry, traction bronchiolectasis. And also we see here better the subpleural sparing. And also we see that the left hemithorax volume is reduced in both the scans. However, there is no retraction of the fissures. And also no honeycombing seen in both the scans. Going to the soft tissue window, this is the latest scan done in June of this year. You can see there is no enlarged mediastinal nodes, just sub-centimeter nodes at station 2R, 5, 6, 4R, 4L. The pulmonary trunk is not dilated. There's also multiple sub-centimeter axillary nodes. Largest is measuring about 0.8 left side. There's no pleural effusion bilaterally. There is minimal pericardial effusion seen in the latest scan. And looking at the abdomen, there is a reverse attenuation of the liver and spleen, in keeping with fatty liver. Otherwise, the rest of the visualized organs, the abdominal organs are unremarkable. However, we look at the esophagus, it is dilated with secretions within, fluid level. So overall, in conclusion, the CT features are in keeping with fibrotic NSIP with minimal progression seen in the latest CT in 2026 compared to 2025. Any questions?
No, Dr. Dinesh, thank you. So, Aaron, CT scan progression while she on, still on cyclosporin, is it? Yeah, so, yeah. So that's why she need a stronger immunosuppression because she's a MCTD, SLE with the MCTD high risk for progression. So so see whether we started tacrolimus, whether she can tolerate the tacrolimus or not, because there's no other option for her. So
Okay.
you update me whether she supposed to be see in 2 weeks time, is it?
Yeah, we are seeing her in 2 weeks.
Yeah,
on
see whether
24.
whether she tolerating the tacrolimus.
All right.
Okay, move to next case from Queen.
Good afternoon, everyone. I'll be presenting Nurul Shahriza from Queen Elizabeth Hospital. This lady is a 32-year-old lady. She's married and blessed with 2 children. Having pulmonary hemosiderosis, was diagnosed in 2000, actually. It's a typo there. Under HKL was diagnosed, then subsequently defaulted. Her has been having, we have been treating her for unlikely, working up for ILD with CT that will be shown after this. Tapi other investigation includes RF, only RF show positivity but quite low. Others are negative ANA, anti-CCP, ENA, and also ANCA, and even myositis panel is negative. Her 6-minute walk test, only 300 meter, 280 to 300 meter with desaturation after. Her echo otherwise shows grossly normal structure and PEP is low, and also EF is preserved. The DSCO is low, the KCO is 102, and FVC is it show increase. It's a restricted pattern otherwise.
All right, thank you for the history. So actually this patient has 4 scans. So the patient has 2 scans in 2022, this March and August, 7 months apart. So the next 2 scans will be in 2024 and 2026. So we have total of 4 scans with 2 years in interval in between. So I'll start off with the 2022 scans. So if you could bear with me, so as I scroll down, you can actually see very subtle ground glass density, like the lung is like very busy, very dirty. It's like very ill-defined ground glass densities in the bilateral lungs. But as we scroll down to the bottom, we can see there is increase in ground glass opacities in the lingular and middle lobe, and also bilateral lower lobe. They are in peripheral as well as peribronchial vascular region. At the same time, we also see there is focal bronchiolectasis, more prominent in the lung bases. Okay. So for the soft tissue window, I actually don't see much of a findings. There is no pleural effusion, no pericardial effusion, but there is lymph nodes, sub-centimeter lymph nodes about 0.9 cm in short axis. Okay, so in this, I would say this could be a fibrotic OP pattern. Yeah, so we moved on to the rest of the scans. So you can see on my bottom 2 is actually 2022 scans. The one on the right side is actually in March, then followed by October 2022. Then subsequently is a 2024 on my top right, as well as 2026 on my top left. So if you could bear with me for a while, it's actually quite a lot of scans. But if you can see, as I scroll from top to bottom, you can see there is increasing in ground glass opacities from the 2022 to 2024. It's actually increasing year by year. Here, predominantly in the bilateral lower lobe, you can see the ground glass opacities as well as the traction bronchiolectasis is actually worsening. Okay. But other than that, other than that. So basically, it looks like there is progression in fibrosis in the fibrotic OP pattern. Yeah. So we still can see those very ill-defined ground glass opacities are diffuse in the bilateral lung, like for example, this one. So on our side, will be fibrotic OP pattern with progression of fibrosis. But can I ask the pulmonary hemosiderosis, is it established diagnosis? Like what are the evidence for the pulmonary hemosiderosis?
As documented in the case note, they did the bronchoscope in HKL. Sputum Prussian blue hemosiderin laden macrophage was treated and started prednisolone. She came with hemoptysis during that time, and then subsequently no more hemoptysis.
So currently no more hemoptysis lah.
Correct.
Okay, right. So I mean, not too sure, but if it's given the history, maybe the ill-defined those ground glass nodules can be because of those deposition of the siderosis. It can be, yeah, if there was evidence before. Yeah. Okay. That's all from my side. Any questions?
Yeah, thank you, Gloria. So this patient seems history is she started since 2000 when she's still a teenager time. She's still I think 7 years old, still around 7 years old, yeah, 6 or 7 years old. So under pediatric HKL, yeah, seems so. Then when she come to our side in 2022, she was defaulted appointment and not any medication. Seems and so now since the progression, we start hydroxychloroquine. If she tolerate, maybe we put a low dose azathioprine to prevent further progression. So yeah, then we repeat another CT scan in 1 year time and see whether she is worsening or not. Zarif. Zarif?
Yeah, okay, noted.
Yeah,
Dr.
so I
Zul.
think she coming on next Monday clinic appointment. Yeah. So yeah, we can start some immunosuppressant, hydroxychloroquine. No?
All right, will do. Thank you, Dr. Subra and Dr. Gloria.
Okay. So next patient from Queen, she was under GMC follow-up. So 59 years old, married. She was teacher at one of the KK school. So otherwise, no history of allergic, no known medical. She had been medical illness, hypertension, diabetic, and dyslipidemia. Second-hand smoker. So came with a chronic cough for 2 years with a worsening whitish sputum associated with reduced effort tolerance since 2024, easily triggered by cold and coughing. So also had some resting, shortness of breath, worsening address, and exertional dyspnea, bilateral leg swelling. And so she was treated under JMC for a fluid overload, planned for angiogram. So CTD workup we done is negatives, and so since she was at home at 78, she came to Queen Hospital. So treated as a fibrotic fibrotic NSIP in exacerbation and given some methylpred. So I want to discuss the CT finding. Another CT scan we repeated in Queen. So we want to compare and discuss.
Thank you for the history again. Just let me share my slide. Okay, so we have two scans here. One is in April 2026. Another one is in May. So it's about 1 month differences. So for patient Agatha, so I will first show the April 2026. This is from JMC. So as we scroll down, we can actually see peripheral ground glass opacities, more of ground glass. But at the same time, we also saw traction bronchiectasis. It has apical basal gradient, more of the bases. And some areas, you do see some subpleural sparing. Okay, as we scroll down, we can see there is areas of perilobular densities. But otherwise, heart is enlarged. You can see a bit of thin pericardial effusion, and pulmonary trunk is also dilated in this skin study. So with this, we conclude that this is a fibrotic NSIP-OP pattern. So we moved on to the next scan. So in 1 month's time, we actually can see there is not much of progression. We can still see ground glass, peripheral ground glass opacities with traction bronchiectasis. But I don't think there is any progression of the ground glass opacities. It's still the same areas of involvement. There's no worsening of traction bronchiectasis as well. So basically, it's a fibrotic OP pattern with no disease progression as of now. Yeah, that's all from my side. Any questions?
Sorry for the repeated CT. I mean, we repeated because initially from GMC we only got thick slides.
I see.
They didn't give me the thin slides, so that's why I asked for the thin slide. So this and fibrotic NSCP could be CTD rated or or possible HP.
Maybe HP. No, is there exposure for this patient? Oh yes, she's
Only
a
the
teacher.
teacher. So I'm not sure that any was that time a chalk. I mean, it was a chalk.
But can be CTD related lah.
Yeah, because on my certificate negative, she don't have CTD features. So anyway, we pass her. Then yeah, I think she improved. Last day we see improve. Yeah. So we see back 1 month times how she doing.
Right.
Kalau HP mungkin indeterminate HP lah. Betul sebelah.
Indeterminate. Okay.
If you are thinking sebab patient ada exposure kan.
Yeah.
Okay.
Okay. Okay. Thank you, Dr. Irene. Thank you, Gloria.
Okay.
So move to last case. So this patient referred from a rheumatoid. So 51 years old housewife with underlying overlap syndrome, RA scleroderma with a renal phenomenon and primary hypertension. RF and anti-CC positive, anti-Rho, anti-La positive. She currently on methotrexate, hydroxychloroquine, and sildenafil. So clinically, MMSE1 not worsening cough. Lung function-wise, the FVC is static in over the 2 years, 2.29, current latest 2.2 liter. And DLC also, the percentage-wise looks static. So I just want to remote to ask if there's any progression in the HRCT.
Thank you for the history. Just okay, okay, so we have 3 sets of scan for this patient. So we have 2023, 2024, as well as 2025 1-year interval for 3 scans. So I will move on to the first scan in 2023. Okay. So from scoring from top to bottom, we can see there is peripheral reticulation with traction bronchiolectasis. So we can, as we scroll down, we can see some areas there is subpleural sparing, but there is basal predominant. Yeah, so you can see more on the basis with the traction bronchiectasis. Okay, so but at the same time, we also see there is some parenchymal band here. You can see a dense line here. So, and then at the same time, we also see volume loss in the left oblique fissure being pulled. So the left, there is left lower lobe volume loss. Okay. So otherwise, we see on the soft tissue window. Okay. So we can see some soft tissue density in the anterior medial segment can be because of tiny hyperplasia, but otherwise we have sub-centimeter lymph nodes, not enlarged. In the medial segment, largest is at the station 6. The pulmonary trunk per se is not dilated. There is no pericardial effusion, no pleural effusion. Upper abdomen has some liver cysts scattered in the bilateral, the liver. Okay. So if we compare to the next 2 scans, which is 1 year apart, the latest scan is actually in 2025. Okay. So as we scroll down, we actually see similar reticulation and also bronchiolectasis. We don't think they are worsening. It's still at the peripheral predominant. There are parenchymal bands still. But in the right lower lobe, in the latest scan, we actually can see some form of consolidation. Sorry. So I think it could be because of infection or exacerbation. Yeah. So all in all, this is the NSIP. It is an NSIP OP pattern. Currently with no disease progression, but consolidation in the latest scan can be because of exacerbation or infection. Okay. Any questions?
I mean, can you where's the consolidation? Because if got present consolidation, I ask them to do bronchoscope washing first.
Yeah, in the lower left. Right lower lobe.
Right, so right lower lobe. So okay.
You can
Okay.
see here is more dense compared to the previous scans. Yeah, but we don't see new areas of involvement, no increase in traction bronchiectasis, no worsening of volume loss.
Yeah. So we plan for the broncho washing. Then, if negative, since it's anti-Ro 52 positive, can risk of progression high. So we ask them to start MMF infective markers. I mean, cultures negative. Okay, thank you, everyone. Our next MDT in 2 weeks' time. So in July, I have 3 slots. Okay.
All right, thank you.
Okay.